Thanks, Hazel. Good afternoon, everyone. It's great to see so many familiar names. Can't see many faces at this time, but great to see the names. But for those who don't know me, I am Rob Hebdon. I'm one of the National Pharmacy Integration Leads at NHS England, and I work on smoking, a lead on smoking cessation services within the team. You'll be really reassured to know that I also work quite closely with colleagues in NHS England's prevention and cancer teams, and also with OHID. So just wanted to start things off by offering a bit of background to the nationally commissioned NHS Community Pharmacy Smoking Cessation Service. Now, we love our acronyms in the NHS, and this is no different. This service has helpfully been abbreviated to SCS, and that's how I'll refer to it through the rest of the presentation. Now, for me, SCS represented a bit of a breakthrough for community pharmacy-based tobacco dependency treatment services, because for the first time ever, we had this nationally commissioned, consistent and equitable offer for patients. Until this point, we had the complexity that your Menti poll just described there. We had a myriad of locally commissioned services, all different in terms of who can access, what support could be offered, and what role, if any, the community pharmacy teams would play in that service. So back to SCS, from a policy perspective, the SCS comfortably aligns with the prevention ambitions that have been described within the NHS long-term plan. That's where we sit. And it represents a bit of from an evidence base, I guess, it represents an interpretation of the Ottawa model for smoking cessation. Now, I appreciate I'm talking to an informed audience here, but just as a reminder, the Ottawa model is considered by many the gold standard for actions within secondary care. But in a nutshell, kind of demonstrates that the best outcomes are attained when patients are offered consistent, coordinated, seamlessly joined up support with their quit attempt. And this is what we've tried to achieve with SCS, as I'm sure we've tried to achieve with other pathways. So with SCS, a typical patient journey would start with the smoking status being captured on admission, and that they will be visited as soon as possible by a trust-based tobacco dependency advisor. And where support is accepted, this team will support that inpatient through this stay. This is a familiar story to many of you, I'm sure. So as an inpatient then moves, who has accepted support from the tobacco dependency team during the hospital stay, nears discharge, they will then be offered the opportunity to continue their quit attempt post-discharge. And if the inpatient then consents to this, then they'll be offered community pharmacy as one of the potential destinations for their continued support. Now, this is the first thing I just wanted to expand on a little bit with everybody. One of the big learning points from the pilots that preceded the national service. Just wanted to share this with you. Hazel touched on her own perceptions of what a community pharmacy delivers and the role that they have in the community. But what we didn't know at NHS England, we didn't know whether in this particular circumstance, where the hospital, whether it be acute or mental health inpatients, would consider community pharmacy as an appropriate partner for a hospital referral. I'm pleased to say, I probably wouldn't be here speaking to you if it went any other way, but the pilot did demonstrate the patients were more than comfortable with this option. And the reasons for that we captured during the evaluation included things like accessibility of the community pharmacy and existing relationships. So back to the SCS pathway. So once a referral is shared, community pharmacy teams are then able to offer support through consultation, which could either be face-to-face or remote, and importantly, supply of NRT for a step-down quit attempt for up to 12 weeks. So just to reiterate, this is a support and a supply service. And again, I know I'm talking to an informed audience, and we all appreciate how important that is. But just onto the launch of SCS. For many of you, this might be the first time that you're hearing about this, and that wouldn't surprise me because SCS did receive a very intentional soft launch. So currently SCS is only available through acute and mental health trusts, and only when those trusts have a tobacco dependency team in place and able to manage referrals. We have nearly 200, I think it is, acute and mental health trusts across England, and all of those trusts are at very different positions in terms of recruiting to and implementing their part of the service and their part of the pathway. This being the reason behind the intentional soft launch. We simply didn't want the entire community pharmacy network to mobilize, invest in time, training and smokealizers. If there was a risk that they may not receive a referral for it, in some cases must be maybe even greater than 18 months. So this brings me onto where we currently are, where we're currently up to with SCS. Claire, are you okay to just quickly share my slide? Well, I can see that. Hopefully everybody else can. So just to talk through this slide, the graph on the top left shows the number of pharmacies registered to deliver the service as a dark blue line, and the light blue line describes the number of acute trusts that are going live with the pathway. We haven't yet added in mental health trusts to this because as a commission from NHS England to the CSU, we didn't add mental health trusts into their implementation work until much later on in the commission. So yeah, what we've got here is a quick comment on the pharmacy line. You can see that despite the soft launch, there was a huge amount of initial interest from community pharmacy for this service, which is really, really encouraging. And that's leveled off over time, kind of plateaued off now. And we're in a position now where registrations are largely driven by deliberate local engagement directly linked to when the implementation team is confident of a trust going live. So we do see, like last month, we gained another 100 community pharmacy registrations based purely on that kind of activity. The smaller graph just to the bottom left there represents the consultation activity. It was just a very, very easy way for me to demonstrate how activity within the service has kind of taken off. So it obviously there, you can see yourself, it obviously took a little bit of a time for the service to get going, but this is obviously moving in the right direction, in a more positive direction, as we see more and more trusts going live and more referrals being shared with the pharmacy teams. So the current state of play is that we currently have over 4,000 community pharmacies signed up to say that they're ready to accept referrals for the service. The image on the right-hand side of this slide is taken from the CSU implementation team dashboard, which I'm sure they'd be happy to share the link to, and shows the national distribution of those 4,000 pharmacies. So we currently have these 4,000 pharmacies registered, so that they are ready to accept referrals from the 50 or 60 NHS trusts that are currently live with the pathway. And so far, we are aware of over 600 referrals being made to community pharmacy. And although I have to acknowledge these are small numbers at this time, I'm also really keen to share that where we have community pharmacy teams engaged and trusts reporting in to the dashboard, we're seeing great outcomes in terms of converting referrals into consultations. And then when a patient is successfully recruited and committed to a quit attempt, we are seeing quit rates into the 50%, which I hope you all agree is really, really positive outcomes. Final point from me, all of this wouldn't have been possible without the support of the CSU implementation team and with the engagement and collaboration of those local stakeholders. And I know that my colleagues are going to talk in depth about their experience in the next part of the agenda. So that's my update, Hazel. I'm hoping that's provided a nice segue for you into the next part of the agenda. But thanks everybody for coming, and thanks for listening.